Welcome to the class, everyone. I'm your host, and today we are executing a high-yield comprehensive exam prep explainer on the complete lifespan management of cleft lip and palate. As a maxillofacial professor, I can promise you this topic is heavily tested on the boards because it demands an absolute mastery of staging. You know, we aren't just fixing a localized defect here. We are orchestrating a multi-decade treatment plan. So grab your coffee, get your notebooks ready, and let's get into it.
Okay, let's start by wrapping our heads around the sheer magnitude of the clinical need. Take a look at this number, 53,500. In Egypt alone, the ratio of cleft cases is 1 in every 700 births. That equates to about 3,500 brand new cases every single year. Now, when you multiply that by the 15-year average time span required to fully treat a case, you realize we are managing 53,500 active cases at any given time. The clinical burden is absolutely massive.
Here is our roadmap for today's masterclass. We're covering neonatal assessment and triage, the interdisciplinary cleft team, primary lip and palate repair, functional impacts on hearing and speech, orthodontics in mixed dentition, and finally, alveolar cleft grafting mastery. All right, jumping right into Section 1, neonatal assessment and triage. We literally begin at birth. When a child presents with a cleft, your immediate triage focuses on feeding and the airway. Feeding has to happen at a 45-degree angle, never ever flat, using special squeezable bottles, because these babies just can't generate negative suckling pressure. But listen, the absolute priority is the airway. You have to recognize this clinical red flag right here. Pierre-Robin sequence. If you see an isolated cleft palate, you must actively look for micrognathia, which is a small jaw, and glossoptosis, which is the tongue displacing downward and backward. Since the jaw is so small, the tongue gets pushed straight back into the airway. This demands immediate attention to prevent total airway collapse. Highlight this triad, underline it, star it. It is absolutely guaranteed to show up on your boards.
Moving to Section 2, the interdisciplinary cleft team.
Once that neonate is stabilized, we have to establish our care paradigm. And let me be perfectly clear, managing this defect is never a solo endeavor. Let's compare these care models. Monodisciplinary care, where some rogue surgeon tries to treat the patient alone, that is officially obsolete and unsuccessful. It leaves massive, unacceptable gaps in care. Interdisciplinary care is the strict gold standard. To actually meet the Euroclef standard, a surgeon has to be part of a dedicated team. We're talking pediatricians, audiologists, speech pathologists, orthodontists, and maintain a minimum of 50 cases per year.
I need you to burn this timeline into your brain. This chronological protocol is the backbone of all cleft management. Notice the absolute precision here. Assessment and molding in the first 6 weeks, lip repair at 3 to 6 months, palate repair at 9 to 18 months, and bone grafting way later, between 7 and 12 years. Do not mix up these stages on exam day.
Section 3, primary lip and palate repair. Let's look at the actual physical interventions.
Take a look at the device on your screen. That is the NAM, or Naso-Alveolar Molding device. See how the palatal plate hooks up to a little spring that presses right into the nasal cartilage? This has to be placed strictly in the first 6 weeks of life, while that cartilage is still moldable. Why do we do this? Well, it actively lengthens the columella, defines the nasal tip, and crucially reduces the width of the cleft gap. This dramatically minimizes tension and scarring during the actual surgery. It's a total game changer. Now, whatever you do, do not miss this sequence. The surgical timing for primary lip repair, usually the Millard repair, is absolutely dictated by the strictly enforced rule of 10s. Before you even think about bringing that infant into the OR, they must be at least 10 weeks old, weigh 10 pounds, and have a hemoglobin level of 10 milligrams per deciliter. This is non-negotiable. It's exactly how we ensure safe healing.
All right, Section 4, functional impacts on hearing and speech.
Remember, we repair the primary palate mainly for functional value, feeding, airway, and of course, hearing and speech. This image brilliantly illustrates exactly why a cleft palate causes conductive hearing loss. On the left, you've got normal anatomy. Now look at the eustachian tube on the right. Because those palatal muscles are completely abnormal and detached, they fail to pull the eustachian tube open from the nasopharynx. So when the baby drinks milk, it stagnates, bacteria grows, and boom, you get secondary otitis media. Fluid backs up, the ossicles can't vibrate, and sound conduction just completely stops.
Make sure you highlight this statistic for your exams. A massive 70% of patients will require ENT intervention with puncture incisions through the eardrum. Simply fixing the palate does not automatically fix middle ear drainage. You've got to anticipate the need for ventilation tubes like grommets.
Then we have speech, which is the other major functional hurdle. If the palate is scarred or shortened during palatoplasty, the soft palate literally cannot stretch back to touch the posterior pharyngeal wall. This creates a leaky valve, which we call velopharyngeal incompetence, or VPI. The clinical sign, severe hypernasality of speech. If speech therapy doesn't cut it, the surgeon has to go back in, often using buccal myomucosal flaps from the inside of the cheeks just to lengthen that palate.
Section 5, Orthodontics in Mixed Dentition. Fast forward to ages 7 to 12. Preparing for bone grafting becomes our primary focus here. Maxillary growth is often deficient in all 3 dimensions because of the scar tissue from those childhood surgeries. Now ask yourself this high-yield question. Why must we strictly delay fixed orthodontic alignment at this stage? I see students fall for this trap constantly because it is so tempting to just straighten those severely malaligned central incisors right away.
Well, the answer is catastrophic tooth loss. Moving teeth adjacent to the cleft without placing the bone graft first will completely destroy the remaining bony shelf. You're applying orthodontic forces to teeth that have 0 bony support. When you finally take that wire off, these central incisors will literally fall out, widening the cleft gap and massively increasing your burden of care. It's a clinical disaster.
So, what's the actual protocol? The orthodontist sequence has to be followed to the letter. Step 1. Maxillary expansion to fix the crossbite, usually with the quad helix. Step 2. Mid-phase protraction using reverse pull headgear. Step 3. Alignment is strictly delayed. You absolutely do not align those teeth until 3 to 6 months after the maxillofacial surgeon restores that alveolar defect.
Finally, Section 6, Alveolar Cleft Grafting Mastery.
We have arrived at the absolute pinnacle of childhood surgical intervention. ACG provides the foundation for the adult teeth, stabilizes the maxilla, and supports the alar base for future rhinoplasty. Memorize this table. The timing of ACG is totally dependent on the child's dental development, which you verify with a panoramic X-ray. Secondary ACG, timed just before the canines erupt, is your ideal target, the absolute gold standard. Notice that primary grafting, which used to be done during the initial lip repair, is now totally obsolete. It mobilizes the tissue too much and causes severe growth-restricting scarring.
Let's talk surgical parameters. Your gold standard autogenous extraoral graft source, the anterior iliac crest. For really small defects, under 2 cubic centimeters, you could use the symphysis intraorally. Before you cut, you absolutely must verify the bone development with a CBCT scan. It's the most accurate tool we have. And the greatest risk during surgery? Failing to get a watertight soft tissue closure. That'll cause an oronasal fistula and total loss of your graft.
And please, never forget the exact dental milestone you need for surgical clearance. I call this the root rule. Exactly half the root of the erupting tooth must be formed. Not a third, not fully formed. Exactly half. If you wait until the root is fully formed and the tip of the tooth is poking into the cavity, the bone graft simply won't attach properly to the enamel, and your risk of surgical failure goes through the roof.
So to bring this all together, remember this core guideline. Mastering cleft care means mastering the precise staging of interdisciplinary interventions over literally decades of a patient's life. You can't rush it. Every single specialty, from the pediatrician to the orthodontist to the maxillofacial surgeon, has to pass the baton at the exact right moment. I'm going to leave you with this ultimate clinical scenario to test what we just covered. Think about the timeline we discussed. Think about the mixed dentition phase, and think about who needs to prep that bone before surgery. Review your notes, trust the protocol, and good luck on your exams.